Hello, it's Dr. Felix Lee, and today I want to talk about a very important topic: how to prevent vascular complications and blindness in filler injections. Now, before we begin, some of you who know me may know that I train for a major international brand of fillers, but I need to emphasize that all the views in this video are my own and they do not represent the views of any company or institute. Now, let me start by showing the only place we can inject a filler with a 0% chance of blindness, and it's here, not in the patient's face. The moment we inject our patients, it carries an inherent risk. So why do we persist in doing it? Why do we do fillers? Because when we do fillers, the results from the treatment oftentimes bring a big improvement or change to the patient's self-perception, their self-image, their self-confidence, and their quality of life. This is collaborated by multiple international studies on quality of life. So we are injecting fillers because of all these benefits that it brings for the patient, but at the same time, because the risk is very, very low. However, filler injections is a life-enhancing and not a life-saving treatment, and therefore a devastating risk like blindness should ideally never happen with such a procedure. The most important thing to think of to prevent this complication is to respect the fact that it can happen. I have been injecting fillers for over 5 years, over thousands of syringes of fillers, and I have never got a single vascular event. However, with every syringe of filler that I inject, this risk is first and foremost on my mind. And I do everything I can to hopefully go through my entire career without a single case like this happening. Now, if we do not do everything in our power to reduce this risk to the very minimum, then we cannot honestly say that this risk is so-called very, very low. A vascular complication happens when a blood vessel is obstructed by a filler. This obstruction could be intravascular, which is that the filler is inside the blood vessel, blocking it off, or extravascular, which means that the filler is outside the vessel, pushing it closed. What happens then is that blood flow from this blood vessel is cut off, and the organ that is supplied by this blood vessel no longer gets its blood supply. So when this happens in the skin may die or necrose. And if this unfortunately happens to the eye, then the patient could potentially go blind. First and foremost, avoid danger zones. We all know that injecting in the lower forehead, in the brows, the frown lines, the so-called static 11 lines, in the nose, and in the nasolabial folds superficially are the areas in the face that carry the highest risk of blindness. This is because the vessels in this area have the clearest path or connection to the vessels that go into the eye, into the internal carotid circulation that can lead to blindness. So exercise great care when injecting in the danger zones. Always think, is there an alternative treatment for the patient? However, avoiding danger zones may reduce the risk of blindness, but it does not reduce the risk of vascular complications. If the blood vessel is blocked in another area, even if the product cannot travel to the vessels that supply the eye, it will still cause obstruction in that area, which can lead to skin necrosis, which may or may not heal fully. It may lead to sequelae such as scarring. So it is really, really important to, yes, avoid danger zones, but more importantly, to have good injection technique. This is just like driving dangerously along a cliff which has a 1,000 foot fall down into the ocean. Okay, if you inject in a danger zone, it is akin to driving dangerously on such a road whereby if something goes wrong, an accident happens, the results will be devastating and catastrophic. However, even if you're driving on a big, safe road in the city, if you drive dangerously, you could still get into an accident. And while the consequence may not be as severe, it is oftentimes just as bad for many of our patients. We always talk about how important it is to know your anatomy, to know where the blood vessels are. However, when you hear things like in this area, 1 centimeter above this bone, 2 cm to the left, to the right of this bone, there are no blood vessels, this is not true. And we have seen in multiple cadaveric dissections that while there is a roadmap to the blood vessels in our face, there is this very important thing called variation. Everybody is different, and the blood vessel may not be where you think it is. It is still important to understand surface anatomy or topographical anatomy to avoid danger zones in general, but you cannot imagine that the vessel is exactly where you think it is because there is so much variation in every face. Our faces are not 2-dimensional in nature. Our faces are 3-dimensional, and the most important dimension is depth. We may not be able to control variations amongst our patients, but we can control the depth of our injections. Similarly, injecting a hyaluronic acid-based product, a HA product that can be dissolved, does make it safer in terms of vascular complications because we can dissolve the product in such a situation, unlike a non-HA product, a non-HA filler such as a collagen stimulator that cannot be effectively dissolved with an antidote. But this still does not reduce the risk of blindness because it has been shown in multiple studies that once the product enters the central retinal artery, which is the artery responsible for the complication of blindness, it is extremely difficult to get the antidote to the product, even if it's a dissolvable HA product, unless with special techniques such as interventional radiology. But even then, there is limited studies around the world proving its efficacy. So the golden rule that I set for myself, a rule that I will never ever break, is based on this assumption that there is no blood vessels inside the skin and that there is no blood vessels on the bone, spare for 2 exceptions that we will talk about. So all these blood vessels are in the subcutaneous area or the space between the skin and the bone. There is no exception to this rule. You may hear that, oh, in the very superficial parts of the fat that's close to the skin, there are no blood vessels. I can tell you this is not true. One, when we do cadaveric dissections, you can see many a time that there are many blood vessels that's very, very close to the skin surface. And while most of these vessels are very minor, small vessels, there are exceptions, such as the case of the naked facial artery, where a major artery is only 4 millimeters below the skin. At the same time, I have had colleagues refer such cases to me where they were doing skin boosters, which are injections that's done inside or close to the surface of the skin, and they ran into a vascular occlusion leading to skin necrosis, skin death. So it is totally possible for the product to be just under the skin. Now, what does this mean practically? This means that when I use a sharp needle, a needle that can puncture a blood vessel, I only inject in 2 planes. One, in the skin itself. So this is pertinent once again, as I mentioned, about skin boosters, whereby with a sharp needle injection, we can see that a bleb is being formed, that the whole product is delivered inside the skin. The other area that I inject with a sharp needle is on the bone, where in the majority of cases, there are no blood vessels. The 2 exceptions to this rule is 1, the areas in the skull, known as foramen, where the blood vessels pierce the skull and come into the face. And two, in this very, very rare situation whereby the needle could have skewered the blood vessel and pushed it down against the bone. This is why when I inject with a needle on the bone, I will always aspirate. Aspiration has been a controversial topic in recent years, with people saying that there are situations where aspiration is not effective, and more commonly people saying that the process of aspiration could move the syringe and needle, such as the tip of the needle is no longer firmly on the bone. Now, to the latter, I can only say it is extremely important to learn the technique of aspiration, because if the needle is on the bone, there is no blood vessels there, save for the fact that you are in the foramen or you have pushed the blood vessel onto the bone, and in this case, you would have a positive aspiration of blood. You take out the needle and you do not inject. Do I believe in aspiration if you're injecting with a sharp needle in the subcutaneous area where the middle lamella is? I do not. And once again, the reason is based on science and anatomy. This is because when we aspirate, we are trying to see if the tip of the needle is in the vessel. If so, we do not inject. But when you're injecting subcutaneously, the tip of the needle is not fixed. Now, most of the blood vessels, other than say the facial artery or the superficial temporal artery, most of the blood vessels in the face have a diameter of around 1 millimeter. This is very, very small. This means that the process of aspiration, the process of injecting, you breathing, or even the slightest movement by the patient can move the needle tip away from the point that you think you aspirated. So you may think that with a negative aspiration, you are in a safe space, but that movement may have brought the tip of the needle into a blood vessel and you are now injecting the product into the vessel. This is different from if the tip of the needle is firmly on bone, fixed on bone. In that sense, a negative aspiration will give you a greater confidence to inject. So how then do I do it? I never, ever, with no exception, inject in the middle lamella with a sharp needle. So now, how do we inject the middle lamella, the space in between where we know the blood vessels are? We inject these areas with a blunt cannula. A blunt cannula is not sharp tipped and it cannot easily puncture a blood vessel. So whenever we are injecting in an area where we know the vessels are, I will only use a blunt cannula. However, using a blunt cannula does not mean that the cannula cannot puncture the vessel. And the most common sort of cause for this is if you do not have a good cannula technique and you're pushing the cannula with a lot of force, you're essentially holding the skin down and you are trying to push the cannula in with great force. This force can also puncture a vessel. And now when you're using a cannula, if you do puncture a vessel, the cannula will remain in the vessel as you push your product. So what do you do when injecting in the middle lamella with a blunt cannula? First and foremost, cannula technique. You have to be very smooth and very confident with the cannula. The only correct plane is the area where the patient is not in pain, the patient is comfortable, and the cannula is moving freely with very, very minimal force. You should not be forcing or pushing or shoving a cannula in any situation. Secondly, you want to move the cannula as you inject. Whether you are fanning the cannula, you're creating threads, you do not want to use the cannula as a needle by pushing a large amount of product into a single point, because if you were in the vessel, all the product will be in the vessel. So understanding your anatomy and avoiding danger zones is not driving along that dangerous cliff. Understanding your depth is being able to drive well. So understanding that good needle technique, good cannula technique prevents accidents, and avoiding danger zones prevents catastrophic complications such as blindness. Ultrasound is a tool, but not a magic amulet. Do not think that you cannot make your injections safer if you don't invest in an ultrasound. But even more, do not think that if you buy an ultrasound, somehow your injections will be safer. Ultrasound can help us visualize the vessels under the skin. But if you already knew your surface anatomy well, you should have an idea of where these vessels are. Now, injecting in real time under ultrasound guidance can prevent you from injecting inside a vessel. But speaking to an ultrasound expert from Australia, she told me that to really perfect this skill, it takes about 3 to 4 years. Okay, so this is something that we can think about as an advancement in safe injections. But right now, it is incredibly important to follow the golden rules we spoke about and to have good injection techniques, and that will help you more than anything else in preventing complications. What ultrasound can do is it can pinpoint an obstruction if it has happened. So instead of just flooding the area with the antidote, if we can use ultrasound to find the obstructing product, we can dissolve that product accurately. Once again, this does not help so much with blindness because we have already spoken that if the product is in the CRA, it is really hard to get the antidote to the product without interventional radiology. But what it really helps is in the case of vascular obstruction outside of the central retinal artery, then we can directly dissolve the obstructing product and regain blood flow. This brings us nicely to what we can do for the patient should, touch wood, such a complication happens. First and foremost, you have to think about all these and prepare to treat this complication before it happens. Because if it happens and you're right there in the heat of the moment, you should not be thinking about how to treat it. You should not be looking for your highlights. It should be right there in your fridge, ready to be reconstituted and used. What we can do, and this is once again my own opinion, that is a summary of all the talks and conferences I've attended, speaking with experts, my own personal opinion, and the scientific publications that I read. What we can do is a few things. First and foremost, we want to call an interventional radiologist if that service is available in your country. This is based on only a small limited case series, but it showed the best chance of reversing blindness from central retinal artery occlusion because we can deliver the antidote intra-arterially. Without overcomplicating things, the eye is a very closed area and it is difficult to put the antidote into the eye without going through this intra-arterial route. So this is the most direct way, in a sense, to target that obstruction. There is a sort of time limit. Some people think it's 90 minutes, some people think it's 6 hours, 8 hours. But the truth of the matter is, in such a situation, you just want to get the patient treated as early as possible. Okay, what you can do, while maybe you've caught the IR and he's on his way, what you can do in the meantime is to get the most amount of Hyalase into, one, the area that the filler was injected, two, along the course of the blood vessel that you think is obstructed, and you know this based on the skin involvement, and three, retrobulbar Hyalase if you are able to perform retrobulbar Hyalase. If you are not confident in doing retrobulbar Hyalase, you could potentially lead to complications such as a hematoma or even directly injuring the globe, the eye itself. So you could potentially call an ophthalmologist. That has two benefits. Number one, the ophthalmologist is better equipped to diagnose an eye involvement. And number two, the ophthalmologist would be much more well equipped to assess the retrobulbar space for you to inject the higher lace. So you want to do this at a high dose, and you want to do this hour after hour after hour until you get normal capillary refill and the complication is so-called resolved. Once again, I need to highlight that we're talking about vascular complications in general and not specifically blindness, which is much less likely that this treatment would succeed. But once again, you want to call, whether it's an interventional radiologist, whether it's an ophthalmologist, whether it's emergency services, these numbers should be ready in your clinic. You want to deliver high dose pulsed hyaluronidase to where the product is, to the cause of the affected vessel, and if you can, to the retrobulbar space. Now, you have a good understanding of anatomy, you have avoided the danger zones, you have followed the golden rules, you only use needle in the skin or on the bone with aspiration, you only use blunt cannulas in the middle lamella or the subcutaneous space, and you have good cannula technique. It's gentle, smooth, and the procedure is as well done as can be. Does this mean that there is zero risk of vascular complication? It does not. This is still possible, but it is extremely rare. It is therefore important to counsel your patients for this risk. It is not so much to obtain consent as a legal means of self-protection, but to let the patient make this joint decision with you that she believes that the benefits that she will get from the treatment is to her greater than the risk of such a complication. This is important because while we think of this complication as catastrophic in terms of how we may have to pay a large sum of compensation or that it may be crippling to our practice, what is truly catastrophic about this event is that a patient, often young and healthy, is now blind, often irreversibly, from an aesthetic procedure. So I hope that everyone can really respect the possibility of this complication and do everything that you possibly can to prevent it. Now, the views that I expressed in this video are my own. These rules are rules that I set for myself. I'm not necessarily saying that they are right or that you must follow them to the letter, but I hope that you could consider the points and use it maybe as a source of reference for the way that you inject in your practice. And I hope that we can all deliver safer results for all our patients. Thank you very much.